Welcome everyone to today's webinar. I'm Emily Rapley with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You may submit your questions throughout the webinar by typing them into the control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Additionally, in about a week following the webinar, we will send a copy of the presentation to the email you used to register. At this time, I want to thank our webinar sponsor, Leidos, and introduce our presenters. Jeff Tennant is the National Director of Revenue Cycle Solutions for Leidos Health. Jeff has over 25 years of information technology experience, including 15 years in revenue cycle consulting and leadership experience, resulting in millions of dollars of improvement for health systems and other industries. He has been a member of the HIMSS Revenue Cycle Task Force and has presented at the HIMSS National Conference, Arab Health Conference, HFMA events, WEDI, AHIMA, as well as state and regional HIMSS meetings. Joining us today also is Steve Furry, the founder and CEO of Catalyst Healthcare Advisors. For more than 30 years, Steve has assisted hundreds of healthcare providers with their efforts to improve overall performance and reduce costs. He is particularly adept at managing the change process and helping boards, medical staffs, and senior management successfully implement the changes necessary to reposition their organizations for sustainable success. I would like to kickstart our conversation today with a brief overview. Healthcare organizations today face a myriad of disrupting challenges that impact operational and financial performance. Declining reimbursement, the transition from volume-based to value-based payment model, and the complexities associated with building a continuum of accountable care all create a need to find new sources of revenue and operate with far greater efficiency. With careful analysis, meaningful performance improvement opportunities exist throughout the organization. But where do you start? We're excited to hear today from Leidos Health, a leading healthcare IT consulting firm with deep clinical and technical expertise to support customers in selecting, implementing, and optimizing information technology investments. Their professional services help providers define and enhance IT strategy, optimize technology for their clinical workflow, improve the revenue cycle, and meet regulatory requirements. The learning objectives we will cover in the presentation today include: number one, key areas to explore for measurable performance improvement opportunities. Number two, the importance of supplies, contracts, and employee benefits in reducing costs. 3, case study examples of actual results that have been achieved. And 4, success factors for driving performance improvement initiatives. So I'll now turn the floor over to Jeff to discuss market forces impacting healthcare this year.
Hey, Jeff, this is Maggie here. I think that you're on mute.
Sorry about that. Thank you. Not to offend anyone who's on the call in their healthcare knowledge, but these are the market forces that we see impacting healthcare today. And when you look at the numbers and the percentages that are here, with the dollars that are out there that are being left on the table by organizations, it is truly jarring. And when we look at the impact of performing a holistic improvement operation for a healthcare organization, the dollars and the numbers can be startling. And we look at, the PHI breaches that are out there that are in the news all the time, and folks focusing on the security that secures that PHI. When we look at case mix index and how low those are for many organizations, hospitals that struggle with employee compensation, keeping that average. When you look at hospitals having a claim denial rate and 8% or higher, that's really a struggle. And as you look at the operating margin for most healthcare organizations and average out at 3.4%, any impact on these things can drive that margin up or down. So you have such a razor thin margin for error. We feel it's very important to focus on all these areas as you look at healthcare and the whole continuum. Next slide, Steve. So as we look at what are the opportunities for improvement, we think about independent workflows. So are your clinical workflows and your financial workflows and some of the other areas, are they working together to drive improvement and make sure things are flowing as smoothly as they can? You know, healthcare is one of those areas where you have so many interdependencies. You know, is the quality and the efficiency of your staff and your organization working as well as it can? When you think about, you know, patient satisfaction and the value of care that people have and the satisfaction of your employees as well. You know, the more happy, the more excited your employees are about the job that they're doing, the better they're going to provide care for your patients, your clients. And then when we think about this, we really focus on the three different areas: people, process, and technology. Healthcare is still and always will be a very people-focused industry. You have to take into account the people that are providing that service. And our goal is to make sure that the processes that are in place and the technology that's in place to support those really work closely and work in a workflow manner for those people to make them as efficient and effective as they can be in their role in the organization. So as we talked about that holistic approach, right, I believe we have a poll question we wanted to go to prior to this slide. So Emily?
Mm-hmm. Thank you, Jeff. So we would now like to hear from our audience with a poll question. Please select all options that apply by clicking them on your screen. We would love to understand, what is the top challenge your organization faces? And again, you can select all that apply. We'll wait a few moments before closing the poll. Okay, great. Let's go ahead and close the poll. It looks like 53% of the audience chose staffing not aligned with service volume as a top challenge for their organization, followed by 49% who chose inadequate service line profitability and growing length of stay. The next most chosen option was quality metrics that are not adequate. 34% of our audience chose that. 22% of you said high variation in clinical services, and 32% said weak clinician productivity and service levels. So Jeff, I'll go ahead and turn the floor back over to you.
Yes, thank you. And, you know, as we look at these, none of these are necessarily surprising, and it really speaks to the reason we take this holistic approach to what happens in a healthcare organization and looking for improvement, right? So when we look at, you know, an organization as a whole entity and the way the clinical processes drive revenue cycle, and the way revenue cycle and doing that effectively helps you provide the finances to be able to do things to improve your clinical capabilities, you know, add service lines, add equipment, things like that, right? And as we look at, you know, the opportunities to impact the bottom line of a facility, as we improve case mix index, or as we look at helping you to improve your denial rates, you know, all those things just drive a positive cash impact to your bottom line. And as we look at, you know, the satisfaction scores and your hospital-acquired infections, different things that impact you. I think when we look back on the previous slide, there was a significant number of organizations that expected to take a hit, and it was, you know, hundreds of millions of dollars across the country, which is huge. So as we look at ways of improving that, you know, that makes a huge difference. And as I mentioned a moment ago, we truly focus on the people and the processes that support those people, the processes those people do, and then the technology that supports those processes and those people. Steve, can I ask you to share a little bit of the areas that we typically focus on?
Yes. Yeah, thank you, Jeff, and welcome to the webinar, everyone. Thanks for joining us for your afternoon and morning for some of you on the West Coast. You know, we could talk about many areas of improvement, obviously, throughout your organizations. You all, I'm sure, have embarked on a number of these. What we, in the interest of time, what we'd like to do is kind of talk about four, I won't call them kind of foundation areas, but based on the polling question, they They, I think, are going to be interesting to most, if not all of you. There are areas that we think affect service line profitability, which I heard from the polling question. It obviously, we'll talk a little bit about workforce productivity and how the labor component of your expense structure, what areas you can look at to consider implementing sustainable improvement. We'll look at also supply chain, or we like to call it non-labor. Anything you buy or contract for is fair game in our minds, and we would suggest that you include those areas in any analysis and implementation that you embark on. Jeff will take a stab at revenue cycle optimization, looking at the net revenue opportunity for improvement, as well as the cash improvement in some cases. And then we'll talk about a growing area with our clients, and I'm sure in your organizations, this whole idea, we've termed it clinical effectiveness. I know you probably have your own terminology that you use for this area, but it's think of this as the whole improvement in the quality and serviceability of your clinical operation, both inside the inpatient environment, as well as looking at holistically your entire service environment that you provide. And I heard that in the poll, as well as some of you are dealing with variation issues and quality issues. In the clinical world, it's tricky to lead with cost improvement. You don't get many people's attention. If you choose that route, we have in our work with our clients found that if we focus on quality improvement in really all of these areas, but if we focus really on quality improvement, cost improvement follows. There may not be a one-to-one correlation, but there's certainly, we've got enough evidence we can show a focus on quality improvement generally does drive financial performance improvement as well. So what we're going to do is we're going to kind of walk through each of these areas. I know we've got a limited time, and I think in future webinars we'll dive deeper into these areas, and we'll also talk about some of the other areas that you have challenges in terms of your organization that might be performance optimization candidates. Let's first take a look at workforce productivity, or you might call it labor productivity. We suggest that you look at these areas when you consider improvement in the workforce environment. First off is staffing management, and that's really kind of the polling question talked about staffing to service levels. I mean, that's really at the end of the day what we're trying to optimize here is we're trying to align the staffing of the organization at an individual component level, not across holistically. We don't think it's good enough to say a 10% reduction across the board is the way you ought to approach that. That's not what we would suggest at all. We suggest it's a very very distinct and specific effort in terms of looking at each department, each clinical area, and looking at the scheduling of demand that is predictable in some cases, or in some cases not predictable, and putting mechanisms in place so that you can schedule your staffing to that demand. At the end of the day, that's really the majority of what we're looking at here. We suggest you look at skill mix in terms of your workload as well. It's not just a numbers game. We include in our evaluations, and we think you ought to also, in the pay component, the compensation component in this, and typically we find variation across organizations and the opportunity for standardization and elimination of that variation. As you know, recruitment and retention is extremely costly. If you kind of thought about how much it costs to recruit and retain your employees, it's a big number. And so if we can optimize that process, that is very valuable, and and it requires no reductions in terms of staff where we find. And that's a component we want you to understand is we don't think there's necessarily always reductions in all areas of the hospital, in fact, or the health system. In fact, quite often we have improvements in staffing because of high volume and low staffing levels. So it's not a matter of saying we've got to reduce, reduce, reduce. It's very specific. We use benchmarking as our initial stab, and we suggest that you look at various kinds of benchmarking. You know, we all know, or most of us know, the what was called the Truven, now the IBM Watson database. That's a national database, and it's pretty broad, survey based. So, you know, we've used that in the past. We've used various statewide benchmarking databases, or specific disease state databases, or hospital type databases. We also benchmark against past history of the organizations we work with. So it's not just about looking at national benchmarks as the rule of thumb. We think those are a way to indicate where the opportunities might be, but we suggest that you don't rely just on benchmarking to start your efforts. We think you ought to validate those benchmarks against the reality of your organization and its challenges. And there, and only after that, would you then target areas that you think ought to be improved. We also suggest that you look at span of control. You know, the levels of leadership in the organization. It may be time to look at that. It may be time to realign that, particularly for you health systems that are always in dynamic growth mode. It's always a good thing to look at those the spans that exist today and what your organization structure needs to be growing forward. There's lots of opportunity there as well. So, you know, if you look at those two areas, you're going to typically identify some, at least we do in our work with clients, opportunities for cost reduction. And obviously that drives service line profitability in a big way. So those are some of the examples of some of the areas we suggest that you look at. There are others. I'm sure you all have your own examples, but for the most part, we find that we can generate some, you know, pretty good performance improvement opportunity, pretty good number of them with just looking at these areas. We like to think that if you are, you know, considering optimization, that you ought to expect somewhere in the 5 to 15% reduction in workforce cost across the board. You know, again, these will not be across every department, but you know, if you aggregate the total, our experience, at least in our, you know, many years of doing this, is we can generally find somewhere in the 5 to 15. Sometimes we find more, sometimes we find less. I mean, it just depends on the organization, but a good rule of thumb is that 5 to 15% range. We then, you know, we're always looking at non-essential or wasted process, and Jeff mentioned technology. We use technology to boost our productivity in all areas. So, you know, we think there are a number of factors that go into the improvement of this category. Technology is certainly one of them. Process improvement is another. So we like to suggest and teach organizations that they look at the process that we think is an opportunity and reevaluate those non-essential steps, apply technology where it's not being applied, and measure. And I think the important part about this, and we'll talk about this later as a total key indicator of what leads to improvement, is that the whole idea of measuring this performance and the improvement. And we think, and we've experienced, and I think you all probably, I'm sure you all have too, as you go through these processes, we like to take an employee satisfaction benchmark before this process even is initiated, and we like to measure that after, and we like to make sure we focus our efforts so that we don't, you know, the worst case is we don't want employee satisfaction to drop. We in fact want it to improve, and we've got evidence where doing some of this work actually does improve the employee satisfaction scores in organizations. So measure, whether it's this area or some of the other areas. What we'll do for each one of these categories is we'll give you an example, try to cover the spectrum of size in terms of organization size, so that you can kind of see some real live examples of what can happen when you implement some of these kinds of changes. This happens to be just a 300-bed community hospital in the Midwest part of the United States. You know, and your numbers, you might your eyebrows may go up because your numbers may be much better than this, or they might be less than this opportunity. But this was the opportunity that we happened to identify with this particular client. And you'll notice the categories, they're not all clinical. So we're looking at other areas of the organization for performance improvement. And we typically, when we do it, we typically go through a low, medium, low, midpoint, and high exercise so that we kind of gauge the organization's ability to implement change. And, you know, if you want to take baby steps, we typically would try to coach our organizations into looking at the low end of the targeted opportunity. If we've got some experience doing this kind of work in the organization we're working with, we suggest you look maybe at the midpoint. And if you want to be best of breed, you want to kind of push the envelope and be a little more aggressive, then we steer our clients typically to the high end. But somewhere in this range, at least in our experience, we typically will fall at the end of the day. So, as Jeff said, some of these numbers can be quite large. Now this, you know, again, a 300-bed hospital, we're looking at maybe 160 to 170 FTEs, not a huge amount, but very targeted. Below this screen, you would see much more detail in terms of each individual department and where the opportunity was. And our suggestion is you kind of hit the highest opportunities first, target those, and work your way down the list. So that's an example in a a mid-sized kind of community hospital. The second category that we suggest that you take a look at is in the whole area of non-labor or supply chain. You know, they're synonymous. But we got to take a broader view of this category in terms of our definition. You might also, not only is it the supplies that you buy that we think you ought to consider looking at, but it's everything else that you contract for or that you purchase. Some of these may go through your GPO, and we're not suggesting that you always consider the GPO as the issue. We work in our client environments. We work very well with GPOs, and we're not out to replace them necessarily. Obviously, if it makes sense, that's an opportunity. But if it doesn't, we look at both the pricing of these supplies and the utilization of these supplies. So it's not just a pricing exercise. So we look at the utilization and the ability to use other kinds of supplies that that may be typically same quality, little lesser cost. It's not about pricing, not all about pricing. We also include in this category the whole area of employee benefits or HR benefits. So technically you buy those from a third party. So you could argue they would go in the workforce category as well, and we've done that when clients think it's more comfortable there. But generally we put it in the non-labor section, and we suggest that you look at all the areas that are considered in the bucket of employee benefits. You look at your competition and see how rich or how rich your plan is against the competition's plan. That's a good way to kind of gauge where you are. Obviously, some of the organizations we work with use employee benefits, obviously, as a way to hire and retain people. So we don't want to mess with that. But if there's an opportunity and the competition is, a little more savvy than we are, we suggest that we look at that as a potential improvement opportunity. We also talked about compensation in the workforce section. We can also look at it here. If we don't look at it in workforce, obviously we include it in here. And it's really more the pay, not individual pay compensation issues, but more the structure and the standardization. Again, those of you in health systems, as you grow and acquire organizations, I'm sure you're faced with this standardization of the compensation plans that you are faced with. So we typically look at that in either the workforce section or this section, and we happen to include it in both so that we wouldn't forget. And again, typically, you ought to look somewhere in the 5 to 8, maybe even towards the 10% opportunity in terms of reduction in cost, overall spend. And again, timing will be important for both of these. Some of these contracts, obviously in the non-labor and supply chain, are multi-year contracts, so the timing of this savings will be dependent on those contract end dates. We suggest that you look at standardization in this category where possible and where it makes sense. Don't die on every standardization hill, but where it makes sense, we suggest this is the place to look at that. We suggest that you also not just look at pricing, but look at the utilization environment and what is being used as well as the pricing. We suggest you look at almost every contract that exists in the organization. It's a good time to have a contract database if you don't already have one. And we suggest that you set up, once you set that contract database up, that you begin to look at the expiration dates and the opportunity for improvement in the timing of those. And as we talked before, the last area is don't forget the whole area of employee benefits in either this section or the workforce section. Now, what can you expect in terms of opportunity? This happens to be a much larger organization. So those of you on the webinar that tend to be on the high end of the hospital size or health system size, these might be a little more familiar numbers to you. Again, this happens to be just non-labor, supply chain, happens to be a large academic system up in the Northeast. And again, we typically dive into much more detail than just a broad one bucket opportunity. So we divide our opportunities into components, and those components are divided into initiatives. And each one of those initiatives has a project team that's working on it. And those project teams are made up of clinical people, financial folks, IT folks, clinicians, leadership. And so you get a broad spectrum of folks and different angles to look at each and every one of these problems. And the more broadly you can involve the organization, the better your result, in our experience, the better result that you're going to have. So you can look at the spend for some of the areas, the current spend, so the current annual spend in these categories for this organization, and what this happened to be the midpoint target opportunity that we chose for these folks. And we also had a kind of a one-time inventory reduction, and I think we would suggest you also look at that in each and every effort that you do, is look for opportunities to reduce the inventory that you have on hand if you can. And so you can see the numbers. They're much larger, obviously, than the first example. And then we broke it up into supply chain opportunity and employee benefit opportunity in this example. So again, as Jeff said, not trivial in terms of numbers and opportunities. And these are, I wouldn't consider these aggressive opportunity targets either. So we've got organizations we work with that are going after even more than these. And obviously the smaller organizations, the numbers are scalable, but similar in terms of percentage. And again, if you have questions later on, feel free to ask of any of these examples or any of these categories. The next category is revenue cycle, and as Emily said in the beginning, that's Jeff's sweet spot, so I'll have him take this next couple of slides.
Yeah, thank you, Steve, and thank you all again for spending your afternoon with us. As we look at revenue cycle and the things that make up revenue cycle, when we think about revenue cycle optimization, it is a very broad sweeping category. One thing I think that ICD-10, if I can use that four-letter word right now, did bring to the industry was a focus on how much everything within revenue cycle, everything within the coding and documentation area is impacted and has impacts across the healthcare continuum. So everything physicians do, everything your clinicians do, everything your coders do, that all drives changes in your revenue cycle. And as we think about revenue cycle, where does that start? That starts with the first place your patients basically are connected with your organization through a registration clerk of some form or a scheduling clerk. And then the last thing that they typically deal with in your organization is someone related to revenue cycle as they're trying to clean up and get that bill finalized and down to a zero balance. So if you think about revenue cycle as a whole, as we do when we're doing our optimization work, from a patient satisfaction perspective, revenue cycle quite often is the face of your organization. Everything else that happens to and for a patient is, they're under some sort of medication, they're probably not feeling that well, things are happening to them, but the things where they are of clear mind and really not, focused on their health is the revenue cycle. So we look at that as an opportunity to improve patient satisfaction by having an optimized revenue cycle process in place. If we look at, things around reimbursement, what impacts reimbursement? Well, again, everything from that admissions clerk getting the proper information up front, making sure that they're getting the correct insurance information, that they're validating that they've, made sure that the procedures or the things that are happening for that patient are medically necessary, that they've reached out to the clinicians in the event that they need to have an ABN signed to make sure that the diagnosis and what's on that order is accurate, to make sure that that patient can get that covered by their insurances. If we look at, the net revenue improvement and what that means, if you think about denials, I always, when I'm doing these talks, I talk about the fact that every denial, every write-off that you can reverse and turn into a collection, you get twofold that number. So if you can turn $1 million worth of write-offs into $1 million worth of collection, that's a $2 million change in your bottom line. You're no longer taking that $1 million hit, and now you're adding $1 million to your bottom line. There's nowhere else within the revenue cycle or within the healthcare continuum that you can make a change that you get double the impact on things like that. So as we focus on, clinical documentation to make sure that things are medically necessary, so medical necessity isn't an issue. If we look at, charge capture, making sure we're capturing all those charges that are there, looking at, standardization across your entity. If you have multiple healthcare hospitals in your system or multiple practices in your practice, we look at standardizing across those so that your billing and your revenue cycle is as streamlined as it can be. When we think about accounts receivable, right? Nobody likes collecting money from people, and the better and cleaner the whole revenue cycle is, the less confusion and question there is around that accounts receivable collection, right? The better you do getting information to the insurance company, the better you do at collecting from the insurance company, the better people understand their part of that and why they're having to pay what they have to pay. If you focus on point of service collections, right, getting some of that money up front, that starts with your pre-registration, your scheduling clerks, making sure that people know when they come in that they are going to owe a certain amount when they're done, and having the ability to give them an estimated bill of what's going to be covered by their insurance and then what's going to be their responsibility up front. I think people, when they're informed, they feel a lot better about having to make those payments. It's those big surprises, at the end that tend to get people upset. I liken it a lot to when you're flying on an airplane, when you're just sitting there and nobody's talking to you, you tend to get upset. You tend to worry about what's happening. Why are we not moving? If they would just get on and give you an update every 5 or 10 minutes, so what's happening, it's a lot more tolerable. Same thing with your bill. If you know up front what that's going to be, and it's explained to you as the insurance pays and as things happen that, this is why this is what you still owe, it's much more tolerable. When we look at cost to collect, that doesn't necessarily mean that you're cutting people in your collection area or that you're outsourcing that somewhere. As you drive up the amount that you're collecting, the cost to collect that, if you're doing it much more efficiently with the same people, your percentage of cost to collect goes down. So it's not about cutting people, it's about making sure people are functioning in an optimal fashion. As we look at, managed care contract performance, things around, patient access, make sure that you're applying the cash that comes in efficiently and effectively. There's a lot of automation capabilities in cash posting these days, and most organizations are utilizing those, but you'd be surprised how many organizations I go into today that still do a very manual cash posting process, and it makes it difficult. And then as you look at collecting cash from your patients, you want to make sure that you're doing it in a way that your patients do not feel like you're a bill collector. Those organizations that you sign up with, they're representing your organization. So you have to make sure that you have done a very good job of selecting a vendor. If you're going to use an outside collection service for patient balances, let's say, that you've chosen a vendor that does a very good job, and they look out for your patients, and they're focused on patient satisfaction as well, because doing a poor job there, treating those people like they're trying to skip out on a bill, it upsets people. And trying to make sure that patient satisfaction number stays high while you're maximizing your collection efforts is extremely important. And then we take a real hard look at the workflow, right? Looking at how the information flows from patient access through the clinical component of the patient stay, and then through the revenue cycle. And is that done well? If you have an issue with your DNFB, right, is that because your physicians aren't documenting and getting things signed off on? Is it because your coding staff isn't getting the things as they could? There's a lot of different things that we look for there, and we try to standardize those and implement best practices in those spaces. And sometimes it comes down to just having to be the bad guy and put some processes in place that put penalties in for physicians that aren't doing things in a way they should, or making sure that people's productivity is being managed. I think Steve hit on that earlier, that you have to be able to measure certain things in order to be able to manage them, and looking at best practices and what metrics are out there for coders and for physicians, and making sure that they are up to what we would consider industry best practices. But as you look at everything you do to improve your net revenue, and we're not talking about simply charges, we're talking about actual cash back in the door. Everything you do there provides opportunities for better equipment, better services, and additional service lines that could even impact your revenue even more. Next slide, Steve. So as we look at a hospital we've done some revenue cycle improvement with in the past, this is a 900 plus bed public hospital, kind of a safety net hospital in the Southeast, and we were able to reduce their AR balances, what they had hanging out there, by over $21 million, which is, a huge, huge change. We improved their days in AR by 21%. Cash collections went up by 30%. The release of information from Medicaid reduced, significantly. So that then cuts into your people, it cuts out activities that they have to perform. We were able to get transcription errors down significantly by implementing both technology and processes to make sure those were being done well. And then we also improved their coding days. So their DNFB was affected by that as well. Again, over $21 million in this organization. And, Medicaid was their largest payer by far. So if you think about your payer mix and increasing and improving in your area, you can run that across. And this is a very large organization, but still, as you look at where you fit in this with your payer mix and who you deal with, the impact on your organization could be huge. And again, as we were talking about on an earlier slide, when you're talking 3 or 4% margin, an improvement of a couple $1 million can be a huge, huge impact and provide, tremendous care for your community. Steve?
I thought before we jump into the last category, which is clinical effectiveness, one of the things we didn't touch on in this webinar thus far, we've hinted around it, but we've not addressed it directly, and it may come up as a question, so I thought I might head it off, and that is just, how do you go about doing this kind of work? And if we're an organization that has some performance challenges and we'd like to tackle some of these areas, how do you go about getting started? And so let me give you a brief little 2 or 3 minutes on this, and then we'll answer any questions that may come up. And I can consider that maybe another future webinar topic too, as well as in terms of the roadmap that should be used to get through this process. But the effective way that we try to do it, and we suggest that folks that are trying to do this work as well, that you do it kind of in 2 steps, in 2 chunks. One, you do an assessment or a diagnostic front end, where you go through and analyze your own department, analyze your organization, all the departments, looking at maybe looking at best in class in terms of where their workforce numbers ought to be, or where the supply chain dollars should be, and you begin to kind of ferret out some of the opportunity areas that you see. Wow, okay, we're a little different than the average here. Maybe this is an opportunity. Now, we like to coach organizations into kind of tackling all of these areas at the same time because of their interdependencies that Jeff talked about early on. We find it effective to kind of swoop through the organization, tackling each and every one of these areas in a kind of a phased approach, but pretty much at the same time. Some of our clients choose to kind of do phasing where they look at 1 or 2 of these. But I can tell you the first phase ought to be, let's kind of do a diagnostic review of the entire organization, benchmark us against a peer group that we feel comfortable with, and let's figure out where we stand. And that will give you an idea of the volume of effort that it might take for decent improvement. And then we suggest you use a roadmap, a very structured approach, because think about it, you're going to spend a lot of time doing this. You're going to get quite a few people in your organization involved in this, from staff to managers to leadership to physicians to partners that you work with. So it's probably a good idea to get your act together and have a roadmap of where we want to head and prioritize some of the highest opportunity levels to tackle first. And as you get wins in this process, you begin to build momentum, and you can sense that the organization is feeling kind of a huge satisfaction in terms of being able to improve their performance. You can have contests and you can make it fun. We enjoy doing that, where we have contests between departments. So I mean, it's I can tell you it's a intense process. Our projects are typically anywhere, start to finish, anywhere from say 4 or 5 months to 9, 10, 11, 12 months. Some of the larger projects that we worked on have been a couple of years in duration. Of course, we're talking about multi-hospital environments. So, I mean, if you're thinking about doing this, it's, Jeff, I would say it's probably analogous to looking at the implementation of a new, information system in terms of effort.
I'd absolutely agree.
Yeah, and the timing of this is important. We get questions all the time from clients, hey, do I do this before I implement my new, hospital information system, or do I wait and do it after? And we could argue both ways. We kind of lean towards the process of doing this before, because what you begin to do is begin to build in these new improved processes into the IT workflow that you're about to implement. You can do that after the fact, but it's typically additional steps. So the more you can do in conjunction with an IT implementation or before would be the best way to approach this. And I would get as much of the organization involved as possible. I would have your strongest project directors, no matter what department they come from, heading up some of these the larger initiatives, and I think you'll find great success. So the last area is clinical effectiveness. It's probably the broadest area of all, and it's ever changing in our world. So if you've seen one clinical effectiveness performance project to us, you've seen one. Our clients choose to look at their own unique areas for opportunities improvement in this area. And so it becomes the broadest area. It's dynamic. It's ever-changing. And it's probably the most difficult in terms of measuring realistic improvement and getting the inertia of the organization involved in making this happen. But it definitely can be done. We tend to look at process a lot in this area and technology. We've applied quite a bit of technology solutions to the fix in this area. So this isn't, kind of a green space area. We look at workflow is important throughout the organization. Think of this as looking at the clinical operational workflow through the organization and all the handoffs that occur, both inside the acute care environment and outside the acute care environment. And think of all the handoffs that occur and all the inefficiencies that crop up in the process. And so you can imagine how much, how broad this category can be. But we'd like to coach our clients, and we think we suggest that you look at things like workflow. You look at length of stay. You look at the appropriateness of care and the departments that they're in. Two good areas to look at in terms of workflow are the OR and the ER. And how can I optimize workflow through that process? And as you begin to optimize and eliminate the waste and variation and non-essential activities, you begin to drive the quality up and the cost down. And this is where quality really is important. And it's important in all the areas, but particularly clinical quality in this area, we choose to address from the very, very beginning so that we don't impact it obviously negatively, but we look to improve it in all the areas, whether it be patient quality or it's employee quality or clinical quality, whatever the measurement that you choose to use. And that's the other thing that's unique about this section is the way we measure results. These are a little more sophisticated computer, IT systems that we use. We look at third-party products that most of our clients may not have operational. By the way, we look at cost accounting systems as kind of the foundation for all this work we're doing. We understand that not all healthcare organizations have cost accounting systems, but we suggest that you look at some kind of cost accounting capability to drive a lot of this change and a lot of the reporting that's required to keep this sustainable. So back to kind of where we look at, Jeff already mentioned case mix index. So we look at the clinical workflows. We look at the ability to drive length of stay reduction and utilization reduction. We look at standardization. I know that's could be a bad word in clinical operations, but we look at optimal standardization. And obviously our teams in this area are made up of clinicians at the front of the line so that they help drive with their peers the ability to optimize the performance in this area. We're always concerned with outcomes in everything we do in this area. Some of the areas that you may not think about that kind of fall in this area sometimes are things like referral leakage, so leakage outside the system and how the process of referring inside our system works and how we can improve that process and in fact, lots of times improve the leakage that goes outside of our organization in some cases where we're not even aware of it. Here's where I know the polling question, one of the high profile items was service line profitability. Here's where we drive service line profitability. And so we like that reporting to be in place. If it's not in place when we get there, we suggest that you all consider that in your financial reporting so that you can begin to understand what goes into the cost and profit in each one of these areas. And you begin to kind of ferret out some of the winners and some of the ones that aren't so good in terms of profitability. Now, you may choose to still be in that business, and there may be, profitability and revenue down the line that you need to account for. So it's not simply a departmental kind of reporting. But again, this is where this comes into play. We're always looking for the ability to improve the quality while reducing the cost of the service that we are performing, whatever it is. We also look at avoidable conditions in this area. We look at things like, we also look at things like readmissions, and I'm sure most of you have tried to tackle that already and are trying to tackle that as we speak. And it's all about clinical resource consumption, and variance. And here's where we like to do benchmarking inside the organization. We find a lot of times when we help organizations with this process, they're not interested in outside benchmarking all the time. And so what we try to do is compare themselves internally so that they can begin to kind of work with their peers, whether it's a standalone hospital or it's a health system, and begin to kind of improve the performance and clinical effectiveness of the process inside the organization using kind of, peer, I won't say peer pressure, but, peer teaming in terms of those project teams, so that we learn from each other. But it's all about, at the end of the day, all about more efficient clinical workflow throughout the organization. And as we've done in the other areas, we show you kind of a simple example in this area. This can be, the examples in these areas can be very broad. I chose one that was for a small organization because we hadn't shown one before yet in this webinar. But here's a really small safety net hospital in a suburban area where they chose to look at effective length of stay, comparing themselves to the geometric mean, and used Medicare as our benchmark. We looked at service line optimization, and in that area, we looked at profitability of service lines. This organization didn't have a service line profitability measurement process, so we implemented that, and they began to look at the service lines and the services they offer, and began to make decisions, tough decisions on, because this was a financially challenged hospital in this case, and they had to make some tough decisions on what service lines were going to remain and what we needed to kind of partner with within the geographic area that we work in. We looked at referral management leakage here, and while the numbers aren't huge, again, the organization wasn't that large, so you can begin to make a pretty significant impact, even in the small hospitals that some of you represent. We chose in this area to also look at the physician, the employed physician practices and their profitability and their operations, as well as their productivity and measurement. And the client chose to implement some physician productivity measurement processes and started to kind of gear the contracts to those profitability measures. So that was something completely new to them, and you can see the opportunity for improvement that we all were able to drive in this case. So that gives you, it doesn't cover all the areas, we understand that, and we hope to have some future webinars that'll dive into each one of these maybe in a little more detail and actually add some other areas that we know are important. But to us, at the end of the day, the things that make these successful are, Jeff talked about the holistic approach. We think it's because of the interdependencies, whether you're looking at supply chain and revenue cycle and workforce and clinical, or you're looking at the interdependencies of people, process, and technology. It requires a significant holistic approach, much like the implementation of a new IT system. Leadership is key. We like for it to be top down. We think that's where the most success is driven. We like for those that we coach to measure and report their success as they go, and to implement that early on in the process so that it's understandable. We think its prioritization is important because not all the time can we look at impacting everything that we've identified. So we obviously use a prioritization schedule to kind of figure out what makes sense to work on first. We like to use the term hardwiring for sustainable success, and it's in the training that you do, whether it's clinical documentation improvement or it's supply chain management, the training and education that happens in this process hardwires the opportunity for sustainable benefits, and it's important that occur. Obviously, we talked about the quality and cost value is not an option. We kind of take that quality, cost, and value as our equation for success, and we talked about a structured roadmap that's we think is important. Now, that is the slides we had prepared. Now, Emily, I believe we have an opportunity, a little bit of time left for questions from the audience.
Yes, that is correct. So thank you, Jeff and Steve. That was a fantastic presentation. We do have just about 5 minutes left for question and answer session. So as a quick reminder to our audience, you can submit any questions you have by typing them into the control panel in the space labeled Enter a Question for Staff and clicking Send. And we'll try to get through as many questions as we have time for in just the few minutes that we have left. So let's go ahead and get started. For our first question, how do we ensure that quality is positively affected when implementing performance improvement initiatives described today?
So one way to make sure that is being addressed is to set up the measurement process that you're intending to use in quality improvement at the very beginning. So don't make it all about cost. And that involves clinicians at the bedside, in the ambulatory side, at the leadership level, that really wants to come up with what is important to measure, how are we going to measure it, to get clarity on those, and then implement the process before you begin the sustainable, performance improvement. That way, you pretty much guarantee that you're going to address quality as part of this process. I mean, to us, it's all about measurement.
Perfect. Thank you. That's really helpful to understand. So for our next audience question, what area within revenue cycle do you most typically see a need for improvement?
So that's a great question. And in revenue cycle, one of the areas that tends to get neglected is, unfortunately, that patient access area, right? So getting the information up front, getting it correct. A lot of organizations do not do a very good job of their ABN protocols and procedures, right? Most of the time we see as we implement an ABN procedure, it's not about getting the patient on the hook to pay the money. It's about getting the documentation and the diagnoses correct so that it does pass, that medical necessity checking. So I would say patient access and those processes around medical necessity and ABMs is one area we always see. And then the billing and follow-up, right? Having the proper workflows, the proper work listing to do billing and follow-up in an effective manner. It's not always just your biggest accounts or doing an alpha split may not make sense. It's really putting a lot of thought into how your people are attacking the balances that are out there and following up on those insurance balances and then the patient balance after that. So those would be two of the areas that I think we typically see a need for improvement. But throughout the revenue cycle, there's so many interdependencies. There's a lot of areas and a lot of opportunities for things to fall through the cracks and not to be done effectively.
Perfect. That makes a lot of sense. So it looks like we have time for just one more quick question. We have an audience member here who asks, how do you typically engage physicians and clinicians during this process?
So that's a good question. That's a really good question. When we help our clients, and we'd suggest that you kind of consider this too. One, you want to look for those who have a passion for this topic, number one, for improvement in performance, whether it be community health performance, whether it be quality performance, or in some cases, whether it might be economic performance improvement. You look for clinicians who have a passion. Those aren't always in leadership positions, by the way. So you don't need to always look at the org chart for those successes. You get involved in the very beginning. You get all staff involved in the very beginning that are going to work on this process. They begin to become the leaders for each one of these initiatives. Think about this. I mean, each one of these categories, the 4 categories we talked about, probably have, I don't know, 30 to 60 initiatives within each category that could be tackled. So there's a lot of that in the organization to implement this change. So we like to put clinicians in key leadership positions where we think the impact will be dramatic. And we celebrate those successes across the organization. That's another good way of getting recognition for the hard work that's required. You know, physicians and clinicians and overall have extensive day jobs, obviously. And all of you that work in hospitals have extensive day jobs. So it's important to figure out a way to carve out time to tackle these and to measure the success and reward the success for those that are involved. That's really kind of the best way. There's no magic bullet here, but I think getting earlier the process you can get them involved and recognized, the better.
Thank you. I think that will be really helpful for our audience. So unfortunately, that's all the time we have for today. I would like to thank you, Jeff and Steve. That was an excellent presentation. And thank you to our audience for participating today. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.